Hey, welcome to Lecture 4 in a 5-part lecture series over the endocrine system. My name is Matthew Belzer. I'm your instructor, and as always, I've provided you with a set of learning objectives. Before we even get going, what I would do is I would print out the handout that you follow along with, or I would have it up and available to you digitally so you can extract the important information from what we're going over today. So without further ado, let's jump into it. Today we're covering the parathyroid gland and the pineal gland and then accessory glands or accessory endocrine structures. When you think about the parathyroid gland, the thyroid gland rests, right, anterior, just inferior to the larynx. And you can palpate, you can feel the thyroid gland. And in fact, as trained clinicians, you're going to know how to do a thyroid examination. It's called an extraoral examination to feel for things like nodules or bumps that could be indicative of cancers, whatever. The parathyroid glands tend to exist on the posterior aspect of the thyroid gland. And they're about the size of a grain of rice, meaning they're very small, and they're not quite as cleanly delineated as you see in this image. But the parathyroid glands are structurally and functionally unique from the thyroid gland. They have a completely different set of functions. So what we're going to do is we're going to focus on the parathyroid gland today. The first objective is just being able to identify them on a diagram or on one of the lab models. And when we go over the lab or when you attend lab, probably last week, you'll already have had that content. Now, when we look at the thyroid and parathyroid histologically, the delineation between the two is pretty obvious. So when we're out here, what we're looking at here are follicles. So here's the simple cuboidal epithelium that makes up the follicular cells. There's the colloid, and the entire thing is a follicle. And this is where, as we learned in the previous lecture, a thyroid hormone is actually being synthesized with the combination of the activity of the cells and the enzymatic activity in the colloid, right? You can also see those parafollicular cells that produce calcitonin here. We're just a little bit zoomed out. But it's very obvious the transition from the thyroid gland to the parathyroid gland. So here you get these densely packed kind of dark staining cells. The cells that make up the functional component of the parathyroid gland are called chief cells. And what the parathyroid gland does is it produces a hormone called parathyroid hormone, which is very, very important with respect to the regulation of blood calcium. So when you look, here we have a slightly different staining pattern, but we can still see the follicle, the colloid, and we can see the delineation between these follicles and these densely packed chief cells in the parathyroid gland, right? There's an obvious delineation there. The parathyroid gland, in fact, has a little capsule surrounding it, and this tissue is structurally and functionally unique from this tissue. The parathyroid gland serves a unique functional role. And in some respects, it's even more important than the thyroid gland. I hate to say more or less, but man, the regulation of blood calcium is very, very important. So when you look at it surgically, this is somebody who's having a thyroidectomy to have a tumor removed. And one of the things that the surgeon is trying to emphasize here is they've taken the lobe of the thymus, right? So they've pulled up the lobe of the thymus, and they're emphasizing the parathyroid gland on the posterior aspect of the thyroid gland to say, hey, don't cut this. And it's also kind of important to note little things like the recurrent laryngeal nerve, which controls the larynx and allows you to speak. You don't want to accidentally clip that. So surgeons really know their anatomy. And you don't want to take these guys out if you're taking the thyroid gland out, because you need to continue to be able to maintain blood calcium levels. So when you think about parathyroid physiology, we just covered the anatomy, parathyroid physiology. What activates the parathyroid glands? Well, hypocalcemia is low blood calcium. So when calcium levels in the blood are low, that's detected by the chief cells in the parathyroid gland, right? So they function like a receptor. They also function like a control center because they process that information. So you have the parathyroid gland detects and processes or functions like a control center. So it's a receptor and a control center, right? And it releases an effector called parathyroid hormone. Now, parathyroid hormone has three primary targets. Primary target number one I want you to be familiar with is a type of cell in the bone called an osteoclast. Osteoclasts are responsible for carrying out a process called bone resorption. which is the breakdown of bone. And when you break down the mineral components of bone, that allows the release of calcium and phosphate into the blood. So calcium levels increase. Parathyroid hormone also works in the renal tubules or the nephrons in the kidneys, and it upregulates the reabsorption of calcium in the filtrate, meaning you reabsorb more calcium from the fluid that would be urine. And it also plays a role in the activation of vitamin D, which has a downstream effect of causing more calcium to be reabsorbed along the GI tract. The cumulative effect of that is to increase blood calcium. When blood calcium levels increase, it will eventually shut this pathway off. Remember that whenever a pathway, right, whenever the stimulus and the response of a pathway are opposite from one another, you are dealing with a negative feedback pathway. The response negates the stimulus, brings us back into homeostasis. Calcium levels get low, the parathyroid gland brings them back up, right? They get too high, the thyroid gland, and specifically those parafollicular cells, bring it back down. Always antagonistic systems at work because we want to be able to raise things and lower things. So when you think about filling out your table, what is the stimulus for the activation of the parathyroid glands? Low blood calcium. The receptor is the chief cells in the parathyroid gland. The control center is the chief cells in the parathyroid gland. The effector is parathyroid hormone. Parathyroid hormone has three primary targets: osteoclasts, activating osteoclasts. So parathyroid hormone, it's a peptide hormone. In fact, if it's not a steroid or thyroid hormone, it's always going to be an amino acid or a peptide hormone, meaning it's a water-soluble hormone. Binds to the receptor, right, on the osteoclasts, and it upregulates the activity of osteoclasts. They start breaking down bone. They release calcium into the blood. Increases reabsorption of calcium in the kidneys, activates vitamin D, which has a downstream effect of producing or causing more calcium absorption along the GI tract. The cumulative effect of all of those targets, right, being activated by parathyroid hormone is to bring blood calcium levels back up when they get too low. Because the response is opposite from the stimulus, right, it is by definition a negative feedback pathway. Disease is often characterized or classified as when feedback pathways break down. So when you look at like a lab value and you see a reference range, that's showing you the high and the low of some range that whatever it is, in this case calcium, should be within. If it gets too high or it gets too low, that's a disease state, right? That means this feedback pathway isn't working properly and you got to figure out why. So stimulus, gland, hormone, target, don't worry about mechanism and response. Here we're going to kind of focus on this. Now, follow along 3, if you're paying attention to the follow alongs, we're going to talk a little bit about parathyroid pathology, diseases that affect the calcium regulation systems in the parathyroid gland. And I kind of want you to interpret what's happening on this table here. So here we have parathyroid hormone concentrations in the blood in picograms per milliliter, and we have calcium concentration. So we have blood calcium concentration and parathyroid hormone concentrations. Now, when you're looking at this, hyperparathyroidism is an overproduction of parathyroid hormone. You have primary hyperparathyroidism, which stems from the parathyroid gland directly. Things like an overgrowth, the glands grow too quick and they're just overactive, or cancers can cause primary hyperparathyroidism. Secondary hyperparathyroidism, you'll see here, note with primary hyperparathyroidism, calcium levels are also elevated. With secondary hyperparathyroidism, note that calcium levels are low. So even though the parathyroid gland is producing a ton of parathyroid hormone, calcium levels are low. So if you have adequate parathyroid hormone levels and calcium levels are low, it means that you're not getting enough calcium. There's not enough calcium in the body, and you're just breaking down your bone more and more and more, which can predispose you to all sorts of diseases, not the least of which is osteoporosis. So things like vitamin D deficiency. You need vitamin D to be able to absorb calcium along the GI tract. If you can't absorb calcium along the GI tract, right? You're not going to have enough calcium in your blood, and calcium serves a lot of important roles. It's important in neurological function, and what happens at synapses is important in the function of muscles, particularly cardiac muscle. Or you're just not getting enough calcium intake, or the kidneys are failing and you're not being able to reabsorb that calcium like you once did. Bottom line is, this is a case, secondary hyperparathyroidism is a case where the parathyroid gland is doing what it's supposed to, and parathyroid hormone levels are elevated because you're not having enough calcium. Then you get hypoparathyroidism. Surgical resection just means the removal of the parathyroid gland, maybe in a thyroidectomy if the cancer metastasizes there. Autoimmune conditions can destroy that. So let's look at these pathologies and figure out if we can identify whether it's primary, secondary hyperparathyroidism, or hypoparathyroidism. And let's see if we can figure out the signs and symptoms and why they manifest that way. So hyperparathyroidism is going to be our first focus because that's more common than hypoparathyroidism. Remember, primary hyperparathyroidism, right, is an overproduction of parathyroid hormone stemming from the parathyroid gland directly for some reason, whatever that reason is. Oftentimes, it's either the gland has grown too big for some reason, or there's a tumor there. And tumors have this nasty tendency to just keep cranking out hormone, in this case, parathyroid hormone. Secondary, right? What you're going to be looking for is elevated parathyroid hormone levels in the presence of hypocalcemia, meaning low calcium levels. So let's go ahead and start looking at this, and don't worry about tertiary quite yet. So you get this test, and you go blood calcium concentrations in milligrams per deciliter, 8.9 to 10.3. The patient's value is low, right, comparative to the reference range. So that's hypocalcemia. They don't have enough calcium. So you go, oh, that's either a vitamin D deficiency, or this person isn't getting an adequate amount of calcium in the diet, or they have some kind of absorptive disorder along the GI tract, right, where they're not absorbing calcium because there's inflammation in the GI tract. Whatever the reason is, you then look at the parathyroid hormone level concentrations. They're exactly where you'd expect them. Calcium is low. Of course, parathyroid hormone is going to be cranked out. The problem with this is if you don't get enough calcium in your diet, right, or you're not getting enough vitamin D, parathyroid hormone is going to constantly be doing things like breaking down your bones. So with any hyperparathyroidism, weakening of the skeletal system and a predisposition to osteoporosis is very common, right? So you're not getting enough calcium in your diet. Not only do you not have the calcium building blocks for the bone, right? The body is actively breaking it down because you need calcium in the blood to do a variety of different tasks. Low blood calcium concentrations are also dangerous for a variety of other reasons. People tend to feel not good. But one of the primary things I want you to think about with this, with low calcium concentrations, is that it can impact the heart. So you can actually see changes on the EKG, specifically prolonged QT intervals that can lead to really dangerous arrhythmias like torsades de pointe. So you really want to correct this because it can be very hard on the heart, and it can give you what are called arrhythmias, where the heart has trouble regulating its rhythms and contracting effectively to move blood effectively, right? So there you go, right? We have a secondary hyperparathyroidism, and we know if we're following up as clinicians, we go, okay, we need to correct this because that's very dangerous, for example, for the heart. And how are we going to correct this? Well, we're going to figure out what's going on. Is it vitamin D? Is it low dietary calcium intake? Is it a combination of the two? And then you do your further diagnostics. Now let's look at this guy. This is a real patient value. So for the sake of this, let's pay attention to two things. So you have reference range, patient value, calcium, elevated, hypercalcemia, right? So we have elevated blood calcium. And then we come down to parathyroid hormone. Parathyroid hormone is also elevated. If the system was working properly, right, parathyroid hormone levels should be low if there's high calcium levels, right? These should be low because this should shut this system off. The fact that both of them are elevated tells me that this is a primary disorder for this particular feedback. Remember, we're not talking about neuroendocrine control now, right? We're talking about purely endocrine control. So these two are elevated. This should be low. So we know this is a primary disorder. Something's going on with the parathyroid glands directly, right? It could be a tumor, it could be an overgrowth, whatever it is. And then you do the diagnostics to look into that. Hyperparathyroidism and hypercalcemia can be very problematic. It's unpleasant. So you have your parathyroid gland, it's constantly breaking down your bones and causing your kidneys to reabsorb more calcium, etc. Well, there's a saying for the symptoms you get with primary hyperparathyroidism with hypercalcemia. It's bones, stones, groans, and psychiatric overtones. So if parathyroid hormone is constantly activating osteoclasts, it's going to weaken the bone and make it more prone to fracture. If you have elevated calcium that's constantly being filtered into the networks in your kidney, calcium has this tendency to form stones, so you can form kidney stones, which are really painful and super unpleasant. Because smooth muscle contraction is dependent on calcium, throwing off calcium concentrations can actually make these smooth muscle cells a bit more excitable, which can produce cramping because the smooth muscle is contracting all the time. It can make you feel sick. It's not very pleasant. And because neurons rely on calcium, extracellular calcium, having elevated levels of extracellular calcium can interfere with what happens at synapses, and it can produce all sorts of things, notably cognitive dysfunction, brain fog, thinking more slowly. So there are lots of different treatments for this. One of them is just surgical removal of like 3 of the 4 parathyroid glands, and that's that parathyroidectomy. So, parathyroid glands, pineal gland. When we think about the pineal gland is part of the epithalamus in the brain, but it has an endocrine function, right? So we talk about it in the brain and we talk about it in the endocrine system. Just on an interest note, the pineal gland is also called your third eye because it's linked to light, and it used to be a primary photoreceptor, but through evolutionary history, it's moved further and further into the brain. So, there's these ideas that the eye of Horus or the eye of Ra are actually ways to tap into your spiritual third eye systems. And if you know how to, link your conscious mind to your pineal gland, you can expand your consciousness and link to the spiritual world in ways that are mystical and amazing. So when you look at the brain, and you look back here at the pineal gland, right? There's that guy right there. The pineal gland, the job of the pineal gland is to produce a chemical messenger or hormone called melatonin. And when we think about what the stimulus for the release of melatonin is, it's absence of light. So the pineal gland is directly linked to the pathways associated with vision and light, the presence or absence of light. So during the day, melatonin levels are very low, right? So light suppresses the release of melatonin. But as it gets darker, right, melatonin levels in the absence of light start to increase and they spike when you're in deep sleep. So some people take melatonin as a supplement to help them sleep. For some people, it's very effective. For other people, it doesn't do anything, right? Because there are lots of different neurotransmitters associated with sleep wake and hormones, and that chemical signaling pathway is complex. But sometimes it does boil down to melatonin, and melatonin can be very, very useful as a supplement. I would try it before I tried Ambien. Let me put it that way. It also gives you cool dreams if you're ever just wanting to have like a night of cool dreams, or you're trying to do practice things like lucid dreaming. Try some melatonin and see if that kickstarts those pathways. So melatonin promotes sleep, and then as we wake up, melatonin levels drop, cortisol levels spike as we realize we have to enter another day in this weird COVID-ridden existence, and you go, oh, that's stressful. So, even though we associate melatonin with the regulation of diurnal rhythms, meaning sleep patterns, melatonin, like everything, does so much more. It has immune effects and it bolsters the immune system. It's an antioxidant. It plays a role in regulating muscle and bone mass. It's important in sexual maturation and reproduction. So, disorders of melatonin can actually have kind of a wide array of symptomologies. Um, People who suffer melatonin disorders, like sleep wake disorders that are linked to melatonin, very common for people who are blind because they're no longer getting that light dark signaling to the brain. That pathway kind of atrophies and is dedicated to other things, and the release of melatonin can be super sporadic. So that's which can lead to weird sleep patterns, right? It's very common for people who are blind to have unusual sleep patterns. So you can supplement with melatonin. There's also an antidepressant on the market called aglomelatin, I think its name is, but I don't know. I may be mispronouncing that. I don't really care. And nor do you. You just want to get through this lecture and not listen to me anymore, which I don't even want to be talking. So aglomelatin is kind of a melatonin agonist, and it treats certain forms of depression. So we don't give melatonin its full due. I don't think we give anything its full due, to be perfectly honest. These systems are so tightly interconnected. So one of the concerns that often crops up with the pineal gland is the pineal gland is very prone to what's called calcification, where essentially the tissue becomes calcified and non-functional. And that's very common. Some people have tried to link that to fluoride in the water. I haven't seen a convincing study on that yet, but that idea is out there. And there are other people who say, who will have decalcification, dietary protocols. And once your pineal gland is decalcified, life will be wonderful again. And I don't know. I'm pretty open minded with respect to stuff like that because the more you learn about medicine, the more you realize you don't know anything. So, um, melatonin and serotonin, by the way, are very closely related. This is a little amino acid derivative, and they can be interconverted. One can be converted to the other, and vice versa, via different enzymatic pathways. And they look almost identical. These small changes at the chemical level produce pretty significant changes at the physiological level. Now, in our final follow along, what I'm going to highlight is we have our traditional endocrine system. But given the fact that a hormone is a chemical messenger secreted directly into the blood that travels through the cardiovascular system and binds to distant target cells, it's important to understand or to be cognizant of the fact that other tissues are capable of producing hormones because a hormone is just a chemical messenger secreted directly into the blood. So some of these we're going to talk about when we get into, for example, the digestive system, right? We'll talk about these guys at a later point. But I am going to highlight just a couple of ones that I think are important. So adipose tissue releases a hormone called leptin. It's a peptide hormone, and its secretion is proportional to fat stores, right? Meaning the more fat you have on your body, the more leptin you release. This is a protective mechanism to prevent overeating because leptin travels to the brain, binds to receptors, and it says, hey, don't be hungry. It suppresses appetite. So leptin is an appetite suppressor. One of the problems with people who have clinically significant obesity is that leptin concentrations are very, very high, right? But remember, there's a third type of endocrine pathology that we're really going to beat to death in the next lecture called insensitivity. So when leptin levels are constantly elevated, leptin receptors in the brain downregulate and neurons become less sensitive to leptin. When neurons become less sensitive to leptin, that hunger pathway is constantly activated and there's no way to shut it off. And that can lead to these very kind of dangerous cycles of just eating and eating and eating because that feedback system that's supposed to suppress your appetite is not working properly. Now, the heart produces a hormone called atrial natriuretic peptide, or ANP. The trigger for release is stretch of the atrial wall, which is indicative of elevated blood pressure or rising blood pressure. And what atrial natriuretic peptide does is it causes you to urinate more, right? It's really what it does. It's a prodiuretic, it is a diuretic. So it causes you to urinate more. It has an antagonistic effect to antidiuretic hormone. When you urinate more, your blood volume goes down. As blood volume goes down, so too does blood pressure. Now, finally, I'm going to talk about the thymus. All of these little hormones produced by the thymus are peptide hormones. Their trigger is unknown, but it could be infection, right? I would postulate that infection is one of them. And what these hormones do is they're important chemical signalers in the immune responses. They play an important role in regulating immune responses. And with that said, that's it for today. So thank you very much. Have a good day.